Just admitting. Okay, so we're going to cover arthritis of the foot first, basically being quite anatomical. I'm not going to go into every single type of arthritis that you can get. I'm not going to go into the etiology because that's all really in the textbook. So it's going to be a bit more practical, a little bit of literature. It's some of it a bit dated, but certainly with the sort of landmark type articles, and then a little bit into the sort of the technique side of things to help these patients. So really what I'm going to cover in the foot are common pathologies. These common pathologies are arthritis of the first MTP joint, which is also known as Hallux rigidus or end-stage degenerative joint disease of the MTP joint. All of you who rotated through my firm would have done a couple of MTP joint fusions, either for arthritis or for Hallux rigidus or severe Hallux valgus with arthritis. So it's tremendously common. I mean, if you're going to be doing any foot surgery or being a generalist, you need to understand a little bit about MTP joint problems, and that may require sort of arthrodesis or arthroplasty or interposition, and we'll discuss some of those. And then, geez, these guys keep joining here. And then we're going to discuss midfoot arthritis, which is also tremendously common. If you ever have a look at someone's hands in the hand clinic and you have a look at those people with Heberdin's nodes and signs of osteoarthritis of the hand, be sure that many of them will have midfoot arthritis. And the midfoot arthritis patients can be pretty miserable with inability to stand on their toes, have big osteophytes, which make it difficult to wear shoes. So we're going to go over midfoot arthritis and then hindfoot arthritis. And then I've got two talks on ankle arthritis. One of them is a little bit more about the etiology, and the other about ankle replacements versus ankle fusions. So let's start with the big toe. The etiology is pretty straightforward, going through the surgical sieve with osteoarthritis being probably the most common, and then the other inflammatory problems. There's also an etiology that's a bit misunderstood, that of Hallux rigidus, Hallux elevatus, where the first metatarsal is quite elevated compared to the lesser rays. And that makes it a bit more difficult for the proximal phalanx to clear the first metatarsal, causing jamming. And I'll demonstrate some cases where the first metatarsal and the proximal phalanx don't have nice motion, and you get asymmetrical wear of the first metatarsal head. And obviously it's a joint that is prone to significant repetitive trauma from soccer, running, rugby, whatever it is. It's a common joint to wear out. There's some additional risk factors that put some patients at more risk. You can almost see when they're in their 20s that they may have a problem in time. And patients who have sort of a flat metatarsal head, I'll show you on the next slide. It's almost like a very square metatarsal head, as opposed to someone with a very round metatarsal head. Those round metatarsal heads are more prone to Hallux valgus, and the square metatarsal head, Hallux rigidus. Obviously, injuries, people with Hallux, with pes planus or flat feet have much higher incidence of Hallux elevatus, and with Hallux rigidus. And some people have hypermobility. A number of times I've examined someone with very early stage MTP joint arthritis, and you do the draw test, and you can really see they have significant sagittal instability, and we all know cartilage doesn't like load under shear, so if you have an unstable joint. And then obviously secondary to a turf toe, it kind of covers most of the etiologies. And then this one of a elevated first ray or Hallux elevatus, which is a bit of an enigma, because sometimes people stand on the cassette to get the x-ray taken, and what they're doing is they're actually standing on the lateral side of their foot, and it looks like the first ray is elevated when it's not. So some people believe it is an entity, and others believe it isn't. But if you think of the biomechanics, it makes sense if you have a look at this snapshot here, you can see that the first ray is quite elevated, and for the phalanx to clear that during dorsiflexion, there's a cam type lesion that develops on the dorsal aspect of the first metatarsal. So this is sort of the causes. The characteristics, well, obviously you need at least 60 degrees of dorsiflexion for normal gait function. I think if you're sprinting and doing excessive exercise a bit more. And obviously it's an age thing. This is the square metatarsal head that I discussed. These patients are much more prone for some reason. Perhaps it's because of the edge loading or something for Hallux rigidus. And the cartilage loss is usually over the very dorsal third or 2/3 of the articular surface to begin with. So Cochrane, he refuted that elevated first ray. He, in his study, showed that there wasn't a really correlation between a gastroc contracture or that there wasn't a difference between patients with a square or rounded head. But other authors have contradicted this. He developed this grading system. Really, it's quite straightforward, not 1, 2, 3, and 4, where it's really just increasing stiffness, decreasing joint space until you get to a grade 4, which has significant pain through the entire range of motion. The relevance of this is that perhaps with grades 0 to 3, a joint preserving procedure might be indicated, and I'll show you some examples of what can be done. The conservative treatments are these, and the surgical treatment really depends on your clinical examination and the stage, and then obviously the patient themselves, their age, their occupation, their expectations. So certainly yoga instructors or people doing ballroom dancing might be more keen to have a joint preserving procedure. So it's quite individualistic or individual specific, and really the conservative options are a little limited. The joint preserving options are a little limited, with colectomy being the most prominent, which entails removing the dorsal third or dorsal quarter of the metatarsal head to improve that cam type impingement as the phalanx clears the metatarsal head, so it goes over the top, and also to take away that area of exposed subchondral bone, because that's where the articular cartilage is missing. And then obviously secondarily to improve the range of motion. Now in most cases you get a great range of motion on the table, and then when you see them sort of 3 months later, they've lost a lot of that range. But they certainly, that doesn't always match their patient-reported outcome scores. The other possibilities, which would be joint sacrificing, would be interposition, arthroplasty, and arthrodesis, of course, and arthroplasty. Okay, colectomies do work in the right patients. You've got to be quite aggressive with these procedures. You've got to take away right down to almost 1/3 of the metatarsal head, taking away that whole dorsal osteophyte. And certainly reasonable results published in the past by Roger Mann and Cochrane. Some of the more recent studies have shown that advantage tails off at the 5 to 10 year follow-ups, which would be really in keeping with what our philosophy is here. It would be to try and maintain motion for as long as possible, so that the other joints, the IP joint, has less stress through it going forward. So certainly when the plantar third of the cartilage is maintained, it's certainly an option in these patients there. And then certainly in patients who have occupations or sports that you want to try and keep motion. This is a patient of mine who had a very stiff MTP joint, and then at the time of the surgery, after removing that prominent dorsal osteophyte and third of the joint, performed this 90-degree plus dorsiflexion, and that's what you want to try and see on the table, having aggressively resected that. That's the sort of the plane of the cut, and then kind of it looks a bit weird when you look at it like that. There's just a hole there. And then in certain individuals, when you want to achieve a little bit more dorsiflexion, so in people who obviously may want to wear high heels, or patients where you don't quite get that 90 degrees on the table, you might add dorsal closing wedge osteotomy, or eponymously Moberg osteotomy. It's quite a simple dorsal Aiken, if you like, which can be fixed with staples or sutures. And so the indications would be more likely in patients who can't achieve 90 degrees on the table, or women, men, whatever, who want a little bit more dorsiflexion. Pretty predictable results. And now there's this sort of debate: is there a difference between hallux rigidus and degenerative joint disease? But I think there is, in a way, because hallux rigidus, really, if you look at the lateral, it always has that dorsal osteophyte, and the plantar third of the joint usually is preserved until quite end stage in the disease. So I think just hallux metatarsophalangeal joint arthritis is another entity with perhaps a different etiology or mechanics, and maybe inflammatory in some cases. Some more results about long-term colectomy, 6 or 7 year follow-ups showing there's a bit of a tail off in the results, and conversion to fusion. But there, interestingly, a number of patients have the colectomy and have significant improvement, and don't require any further surgical intervention. It's a bit like a hip preservation surgery, where you change the shape of the acetabulum so that the arthroplasty is put off for a long period of time, or maybe even forever. You get that femoral head more covered and less shear on the articular cartilage, and that's the goal of the colectomy as well. What about when patients have failed this, or when the joint is a grade 4, certainly not a candidate for colectomy? You're looking at either an arthrodesis, an interposition, or an arthroplasty. And I kind of revert to the study when patients ask whether they can have a joint replacement, because and there have been about 3 or 4 similar trials, randomized controlled trials, showing that the arthroplasties have greater pain than the fusions, and that a high percentage of patients have the implant removed, and removing the implant leaves a big bone void. And in some of these older patients, quite difficult to get union, so you may be left with a bigger problem. The problems with the hallux fusion, obviously, and I'll go into that a bit now, is certainly limitations with some functions, and IP joint arthritis in time. And this trial showed that really the fusion was the gold standard, which is trying to avoid these type of complications. And I have done 1 or 2 arthroplasties just for my own learning, and patients requested it, and certainly wasn't blown away by the clinical results. And most of the time, with a well-positioned arthrodesis, you can have a very functional patient for years. And what is that functional position? The best position, based on some long-term outcome studies, is at fixing the hallux in slight valgus, so 15 degrees of valgus. 20, I think, is probably a bit much, but 10 to 15 degrees of valgus. And the reason why you want a little bit of valgus is that's normal for all of us. We all have a slight valgus. 9 degrees, 10 degrees of valgus is normal. If the hallux is too straight, the incidence of IP joint arthritis is pretty high, and in a short space of time. And the patients also complain of wear or pressure on the medial side of the shoe. So you have to be quite careful about getting that slight valgus. And sometimes it can be difficult if there's a significant hallux valgus deformity, and you're correcting that. You really want to get it straight, and that's not quite the right thing to do. Or if there's significant instability of the TMT joint. So spend a bit of time getting that position, and use fluoroscopy the first 3 times that you do it, and get that slight valgus position. And then the dorsiflexion position is also important. If it's too plantarflexed, then the IP joint is under more stress, as well as pressure on the tip of the hallux. You should be able to do the plate test at the side of the bed, where you fix the dorsiflexion, plantarflexion, and load the foot with a tray or a plate, and the distal pulp of the hallux would sit just a tiny bit off the tray, and with the sort of half flexion of the IP joint engage the tray or the plate. That's the perfect position. And remember, these angles going to get a bit superfluous because some people have a cavus type foot, some people have a flat foot, and the angle between the phalanx and the metatarsal is not really relevant because everyone has a different sort of arch or pitch to their metatarsal. So what's relevant is that test on the table, getting the IP joint just off the loaded foot, and obviously be very careful about rotation. If there's any supination or pronation, use the nail as a guide or goniometer. Pronation loads the medial side of the foot, which leads to a callous and unhappy patient. If you're going to err on anything, a little bit of supination is a bit better tolerated, but sometimes ingrown nails can be an issue. So just that's a good position there. Some other forefoot surgery going on, slight valgus, and reasonable dorsiflexion. The MTP fusions can be done many ways, with the cup and cone reamers being sort of gold standard now. We know from multiple biomechanical studies that cup and cone reamer to prepare the joints using a single lag screw and a dorsal base plate is the strongest construct. The lag screw obviously to get primary compression, and then the plate to neutralize the fixation. But lots of other things have been done. Many people in the past just used K-wires, AO type screws, cross screws, and union rates have improved significantly to around 80, 90%, 95% with this lag screw and dorsal plate. Sometimes quite rudimentary with these earlier studies, but I must say, in my series of MTP fusions, the union rate must be at least 95% or higher, even with quite a smoking population with difficult socioeconomic circumstances in some people. This is an interesting concept. So the change in the intermetatarsal angle with fusion of the MTP joint. So in some instances, you may have a significant hallux valgus deformity together with MTP joint arthritis or instability, and you want to perform an MTP joint fusion. What's going to happen? Where must you set the toe? It's been shown that the intermetatarsal angle improves or changes by about 6 to 10%, 10 degrees following an MTP joint fusion. I think what happens is the EHL and FHL and all the tendons crossing the MTP joint now don't have a moment arm or a bending arm through the joint. They then will obviously work through the TMT joint, and they straighten out that medial ray. So you close down the 1-2 angle. This is an interesting example. So there's a patient with quite significant hallux valgus. He's a 60 or 65-year-old man. He's got a cyst in the metatarsal head that decided to perform an arthrodesis and some other malatoes and stuff. But you can see how the intermetatarsal angle changed at the 3-month follow-up with union on track. So that also means that you must be quite careful with setting the MTP joint position. What about other alternatives? And not every patient is going to say, gee, I'm happy with a fusion. It's going to be good. I can carry on with my yoga and stay wearing my stilettos. Some of them really want to keep motion. And another option is actually interposition arthroplasty. The resection of the bone is minimal. You just remove pretty much the sliver of articular cartilage from the base of the P1 and remove the cartilage from the metatarsal head, and then suture the dorsal capsule. You got to create a flap and then stitch it onto the plantar plate of the joint. And I haven't done many of these, but Coughlin and Hamilton here have published a couple of series subsequent to these articles with fair motion and reasonable results at 2 to 5 years. And there's no bridge burnt here. You haven't lost a lot of bone, and you can always convert to an arthrodesis in time. There's another paper, but older. And what about the interphalangeal joint? So one must always think about when you take away a level of motion in the spine, there's that possibility of problems up and downstream. It's the same in the foot or the hand for that matter. So IP joint arthritis is pretty common. If you look at the sort of 10-year follow-ups, around 20%, and sometimes require arthrodesis of this or treatment. And I think if you look at it carefully, a lot of the time it's because of malposition of the hallux. If you look at this case, IP joint is certainly subluxed, but the hallux is fused too straight. I think it's something to bear in mind, and perhaps we need to think a little bit about joint preservation in some of the earlier cases. So that's enough about hallux rigidus. Are there any questions there, guys? Okay, I'm going to go on to midfoot arthritis. So this is pretty common, and you're going to see a lot of these. The etiology is varied, and it is actually quite a common cause of an acquired flat foot or a progressive collapsing flat foot, where you lose the structure of the medial column and your foot then tips into abduction and valgus, hindfoot valgus. This is forefoot driven hindfoot valgus, so the tripod is broken. And the patient starts pronating like this. But primary arthritis, osteoarthritis is probably the most common cause, and then post-traumatic arthritis, so undertreated tarsal metatarsal injuries, nutcracker type injuries, and then the inflammatory arthritides. Some people just develop TMTJ instability with hallux valgus, and then secondary arthritis of the middle column because there's increased load. And just remember the neuroarthropathies or the Charcot foot. This is a Brodsky type 1, or the anatomical region for the Brodsky type 1 TMT joint instability that 2 or 3% of diabetics will get. So when describing the columns, just remember what's what. So the medial column is the first metatarsal and medial cuneiform, and the middle column, the second and third metatarsals, and the middle, lateral 2 cuneiforms, middle and lateral, and the lateral column being the most mobile, the same as your hand, is the metatarsal cuboid joints. And these joints lock into the keystone, forming a very rigid structure, and you certainly have to have significant rigidity to be able to stand on your toes, walk, propel yourself. Without that, you're quite functionless. And whether it's degenerative or post-traumatic problems in this area can be quite crippling. One of the most common patterns is this. This is obviously a traumatic case, but I'll show you some degenerate cases which result in the same pattern, where the foot tends to abduct. The 5th and 4th metatarsals tend to slip off the cuboid, and that talus first metatarsal angle on the AP is lost, and then there's significant forefoot varus or supination that one gets following everything sort of going off to the side. These joints hardly move, particularly the middle column, but when they do move in an arthritic joint, they're tremendously painful, and they develop these significant osteophytes. The lateral column does move a fair bit together with the calcaneocuboid joint, and certainly a column that we don't really need to arthrodese in most instances. The arthritis in the lateral column is usually due to instability of the medial column and the middle column, where the foot swings around and the nutcracker type of effect. This is a common pattern that I'm sure you will see or have seen in the clinic, where there's a bump over the midfoot, and you can almost tell a diagnosis before you've even looked at the patient in the eye, because you can see this bump and they're limping and they can't stand on their toes, tib posts intact, but this is the midfoot collapse here with abduction, valgus, a bit of hallux valgus, and pain. And just certainly in diabetics, consider a neuroarthropathy as a cause, but this is one of the main reasons. Probably the second most common cause of an acquired flat foot. The most common, obviously, being attenuation of the posterior tibial tendon. And they may also complain of stress and pain along the medial arch and a collapsing foot and inability to balance. You can try these conservative treatments, but once the foot is swinging out like that, you can tell the patient that this is certainly going to get worse and worse with time. The tib and tendon tends to perpetuate the deformity as it pulls on the first ray. It pulls it more lateral, and so the peroneus brevis is also one of the deforming forces. You can try rocker bottom type shoes. I'll tell you what does work the best for midfoot arthritis, in my opinion, is a slight heel raise. So a shoe that's very stiff with a heel raise, with a bit of a drop, means there's no bending motion through the foot. There's no torque when the patient rolls through, a bit like a moon boot, but with a slight heel raise. In that there's a rocker to the shoe. So that does give a lot of relief to patients who are not really surgical candidates, or you really don't want to operate on them because they're mad, or you just don't want to operate on them. So a surgery for midfoot arthritis, I mean, you can remove the bony bump. Sometimes these patients have quite a large osteophyte that's quite easy to access and remove. It's a bit like metatarsal bossing. In some instances, it's not a degenerate joint. It's just quite a large osteophyte there that rubs on a cycling shoe or something, and one can remove that, but still not a quick fix. And then obviously arthrodesis. Now, sometimes there's reasonable alignment of the joints, and you can perform what's called like an in situ fusion, but in many instances you have to reconstruct the midfoot by achieving a decent first metatarsal talus angle and correcting the Neary's angle on the lateral. So it's quite a three-dimensional type of reconstruction, which can be quite technical and quite tricky, sometimes requiring a couple of incisions to get the foot realigned. But basically, the goal is to achieve a bony union, of course, without complications, and then to stop that progression, because what happens is that eventually the medial cuneiform becomes a hard callus that they can't walk on, and then certainly in any sort of neuropathy that becomes a threat to the skin, and then the correction of that becomes even more technical and difficult. There's just a case of an in situ type fusion, very common pattern, middle column arthritis, medial column is intact, and then a middle column fusion there. There's another example where there's a deformity. You can see there's a bit of a flat foot, and abduction through the middle and medial columns, and then 2 incisions to correct this, and a successful arthrodesis. A little bit about the lateral column. The lateral column, a bit like the lateral carpal, metacarpal joints, is very mobile and doesn't tolerate arthrodesis very well. So pressure on that fused lateral column really leads to quite an unhappy patient. So people have come up with all sorts of things, like putting these ceramic beads in the metatarsal cuboid joint and whatnot. And this looks like a disaster to me. It's not my X-ray. But one thing you can do is do an interposition of the metatarsal cuboid joint. So you flap some fascia into the joint and then just after excising the joint. But otherwise, try not to do an arthrodesis of the metatarsal cuboid joint. I'm not entirely happy here. Okay, moving on to the hindfoot. So with hindfoot arthritis, there's often a deformity. I'm just going to mute. Someone's talking to the kid. So yeah, for hindfoot problems are usually associated with significant deformity, and the etiologies are quite similar to the midfoot, where post-trauma, degenerate, ruptured posterior tibial tendon, which then becomes stiff and degenerate, certainly neuromuscular conditions and tarsal coalitions. A lot of different causes of degeneration or problems with the hindfoot. But the main parts of the hindfoot being the talus, calcaneus, and then the cuboid and the navicular, kind of work in synergy. So by performing an arthrodesis in one of the joints, you affect motion through one or both of the other joints. You need to be quite cognizant of this. So performing a talonavicular arthrodesis for arthritis or for significant instability takes away almost 80% of all your hindfoot motion. So if you're going to be doing a talonavicular arthrodesis, in many instances, you might as well perform a subtalar joint arthrodesis as well, because that hardly moves. And then when you perform an arthrodesis of both of them, then it's more of a stable construct, less stress through the fusion site, and perhaps higher union rates. If you perform just a fusion of the calcaneocuboid joint, it's almost like causing a tarsal coalition. So that also locks the hindfoot quite significantly. And performing just an isolated subtalar joint arthrodesis, which is certainly what we do for instability or degenerate problems, you take away quite a lot less of the transverse tarsal joint motion. So of the three joints, the subtalar joint is probably most motion preserving. Interestingly, if you perform a triple arthrodesis, you decrease your ankle range of motion as well. So the ankle was also coupled to the hindfoot. Just a finding by Roger Mann, which I've also seen, and that's probably a reason why almost 100% of people who have a hindfoot fusion, examine them 10, 15 years later, almost 100% of them have some sort of ankle degeneration or arthritis. So these are the conservative options: Arizona brace, injections, and shoes with a rocker bottom, whatnot. So the surgical treatments to correct these deformities and the degenerate joint disease are subtalar fusions and isolation double arthrodesis, which is subtalar and talonavicular. In sometimes, and I'll show you a case, you can perform a talonavicular arthrodesis isolated if it's just that joint. And then, of course, the triple arthrodesis, which includes the calcaneocuboid joint for significant deformity and like that. This is how they sometimes present, with severe deformity, with significant contracture of the soft tissues and a really unbalanced situation. And the goal is really to get the patient with a plantar-grade foot, and that's pain-free. But really what you're trying to do is to save the ankle joint. In these cases, these patients are walking on very crooked hindfoot, and there's a lot of stress to the deltoid and the medial structures, and the ankle is at risk of valgus ankle arthritis in this particular case. So what we're trying to do is get it sounds counterintuitive, because stiffening the foot will then put more stress to the ankle, but the problem is putting a lot of stress to the ankle with this very valgus foot is also a problem, and they're bound to tip into valgus, and then you've got a bigger problem. So the goals are to make it plantar grade, and secondary to save the ankle, or to save it for as long as possible. And these procedures take a long time to get better, in that patients usually take at least a year to reach maximal medical improvement. So it's quite a technical procedure. Certainly no jigs involved. It's a lot of eyeballing, and a lot of fluoroscopy. The goal is to get the hindfoot reduced into about 5 to 10 degrees of valgus. There's a saying in foot and ankle surgery, thou must never varus. So try and stick away from having the hindfoot in varus, concentrate on getting into slight valgus. There's one situation when there's a bit of a valgus ankle arthritis, where the deltoid is a bit insufficient, then you may want to fuse it very straight or slight varus. But if you perform an arthrodesis with too much varus, they complain of lateral overload, fifth metatarsal pain, stress fractures. So you really want to have too much varus. And then if there's, once your hindfoot is corrected, this significant fixed forefoot varus, like this, you see in this picture, you sometimes have to do secondary procedures like a cotton or a TMT joint correction arthrodesis to try and bring that first ray down to balance the tripod. And just remember, in some of these patients, always examine the patient from the top to the bottom and have a look at the alignment of the entire limb. Some of them are significantly valgus in the knee or have knee arthritis. So what happens then if you perform the triple fusion and then a couple of years later they have the knee corrected with an arthroplasty, and the triple might have been fine for them then, but now when the knee straight, it's not right, and they're then walking on the lateral border of their foot. So the goal is to try and get the knee corrected first and then work downstream and then do the triple afterwards. So if you ever have a knee surgeon that says, look, do the foot first, that's incorrect, do the knee first and get them straight if there's dual pathology. What about isolated subtalar fusions? Well, it's quite a tricky joint. This is just a patient with, I think, a post-traumatic arthritis of the subtalar joint. Probably the most common indication for an isolated subtalar fusion is a previous calcaneus fracture. Sometimes trauma or repetitive trauma in the instability. But it's a tricky joint to fuse, and in a lot of the studies have shown that the non-union rate's around 12%. But if it's in situ and you don't have to use bone blocks or correct hindfoot deformities, then quite satisfying in that the union rates are certainly a lot higher than if you have to use a bone block for a collapsed or crushed calcaneus. Some more on the isolated subtalar fusion, and then the talonavicular joints. There's a lot of stress through this joint. It's what we call the acetabulum pedis. So quite prone to osteoarthritis, but like the hip in a way, with a ball and socket type motion, and certainly not uncommon for this to develop some wear and tear. And in this instance, when there's not significant deformity of the or instability of the subtalar joint, might be indicated to just perform a primary arthrodesis of the talonavicular joint and not include the subtalar joint, bearing in mind that it'll take away 80% of that motion. But also a tricky joint to fuse because of the watershed of the navicular, not a great blood supply. Quite tricky to get fixation, like in this example here with 3 screws going in obliquely, and quite hard to get compression. You have to really be meticulous with your joint preparation and using some autograft. But this is the way I like to do it, with a little dorsal plate and 2 or 3 compression type screws, and maybe 1 fully threaded screw. Get good fixation. If you're going to include the subtalar joint, you can also get a screw into the subtalar joint through this little plate. So the plate almost acts as a nice little tension band. So that's the way I like to do an isolated talonavicular fusion. Moving on to triple arthrodesis. So this is certainly the gold standard for treating complex neurological causes of severe hindfoot deformity, be it stiff Charcot-Marie tooth or polio, or severe acquired flat foot or progressive collapsing flat foot becomes stiff and painful and degenerate. This is an interesting study looking at triple arthrodesis in patients followed up for 25 years and then at 44 years. It's not the best thing for a foot to be totally fused. That most patients, 45% of patients had significant pain at 25 years and 55% of patients had significant pain at 44 years. And all of the patients had evidence of ankle degenerative joint disease. So it's not so good for the ankle to be on a fused foot. And so, of course, this TUT is on arthritis of the ankle and the foot, not so much on tendon problems and deformity, but we certainly would strive to maintain motion as far as possible. Where it's applicable, if the patient's not too obese or the instability is not too bad, to try and maintain motion for these reasons. And based on the study, with quite significant morbidity at long-term follow-up with a very fused hindfoot. So there are some downsides to an arthrodesis. There's some other bigger studies looking at 183 triple arthrodeses, showing a high degree of progression to ankle arthritis as well, and that patient satisfaction was correlated quite closely with post-op alignment being a plantar foot. So if it's two varus, quite low scores, and two valgus obviously being the same. Okay, that's enough on the foot. Any questions on foot and ankle foot arthritis there? So really, you need to keep it quite simple. Break it down into anatomical regions. The hallux. There are some other arthritides with the lesser toes, like Freiberg's infection that we covered in another TUT on forefoot problems. That's also pretty much arthritis, but osteonecrosis. But MTP joint arthritis and midfoot arthritis and hindfoot arthritis are probably the most applicable. And then just remember those principles for you guys at that level. So, yeah, I'm going to go through this relatively quickly. So ankle joints, obviously quite a lot different to the hip and the knee. 80% of arthritis of the ankle is post-traumatic in nature. It's a young person's disease, and this is the problem. Whereas arthritis of the hip and the knee is an old person's disease. We're a complex 3-bone system with a very thin soft tissue envelope, sometimes with complex wounds that might have been open at the time of the primary trauma or multiple incisions. So decision making can be a little bit more tricky and complex than some of the other joints. It's also a very small surface area. So the hip surface area is about 1,000 square millimeters, and the knee about the same, and the ankle about 1/3 of that. So if you're just jumping on on one leg, about 5 times your body weight is going through that very small bearing surface with the thinnest but most durable cartilage in the body. Yeah. The ankle fusion is certainly the gold standard of degenerate ankle arthritis, but not everyone's very happy with this, with at least 80% complaining of difficulty walking on uneven ground, climbing stairs. So there's certainly some mobility. At least half of patients at 10-year, 8-year follow-up have degenerate joint disease in some of the other joints, the tail and navicular joint and the midfoot joints as well. So it's certainly not without its compromises, but it's at least quite safe to perform at the time. Certainly when it becomes minimally invasive or arthroscopic, and the gold standard in many patients that we deal with in the post-traumatic setting who are not amenable to arthroplasty for all the said reasons. What about long-term follow-up of ankle fusions? Well, interestingly, the study by Kuster in the 1990s showed that there wasn't really an high incidence of knee arthritis, but significant difference in activity, and had some limitations and disability compared to the contralateral leg. So with all of these sort of downsides to an arthrodesis, what are the alternatives? Well, ankle replacement, ankle transplant, what's that? I'll show you some crazy stuff the guys are doing in California. Obviously, motion preserving procedures, tibial osteotomies, to try and preserve motion for as long as possible. The challenges of total ankle replacements is the surface area, which I discussed, the bone implant interface, and in some instances, the bone that's been involved in a trauma situation, which might be compromised, and the high stresses. The other is the angiozones that you cross in the approach to an ankle arthroplasty. There's only one ankle arthroplasty that approaches from lateral, which is transfibular. All the others come in from the front, which crosses a major angiozome to the front of the ankle and can lead to this disastrous situation. So that's another sort of con. And then these complex trauma cases, we know that subchondral bone strength, once resected the subchondral bone down to 4-6, you're probably usually resecting about 4 to 6 millimeters. The load that's tolerated by the bone, metaphyseal bone, decreases significantly with the resection following the implant placement. So these are all factors that may lead to an inferior outcome following an ankle arthroplasty and need to be taken into account. The other is this very small surface area and polyethylene contact with the cobalt chrome. These implants are the same as the knee, except we know now that uncemented implants fare much better with primary osseointegration as opposed to using cement, which they did in the past. But the bearing surface is under significant load and wear, and then obviously polyethylene disease is a bit of a problem, and cyst formation, destabilizing both the talus and the tibia, have certainly been found to be the major cause of aseptic loosening and implant failure. There are a lot of different designs, starting off with the very first generation, which were total failures, highly constrained, cemented type of implants, which were really just made, not thinking about the ankle as a complex, not a simple hinge, but a complex hinge which has multiple centers of rotation. They also relied on excessive bone resection, and then obviously significant stress transfer from the bone to the implant. And so as people began to understand a little bit more about the ankle joint and subsequent research began to show that cement's not well tolerated in the distal tibia and the talus, and that primary integration was required. And improving hardware led to second generation implants, which have slowly improved over time to now what we have, probably at least 30 different implants on the market around the world, with the most common theme being minimal bone resection, most being a fixed bearing type polyethylene, and then a tibial tray with a different type of shaped keels. The problem with a lot of these implants is they're all quite different, and the joint registries in the US and certainly in large parts of Europe haven't been all inclusive, and so we're getting this mixed match data, and we're not quite sure exactly which implant is outlasting the others. But in a meta-analysis that was published last year, you can certainly get some data from New Zealand and the Scandinavian registries, which have shown with the STAR implant, which is this one over here, that the survival rates are about 86% at 10 years in multi-center long-term follow-ups. And with the Salto, which is a Tornio one, which is just leaving the market in South Africa, unfortunately, the 10-year survival with that implant was about 88%. So certainly not infallible, not anywhere near the hip and the knee, but I think now with increased research into the polyethylene and making it highly cross-linked, using vitamin E and all the technology that's been involved in hips and the knees, the ankles are slowly starting to catch up. The problem is we're not always dealing with simple, straightforward, uniform ankle arthritis. There's often significant deformity as well, which I'll show you a couple of examples of, which sometimes preclude, or they may affect the longevity of the ankle replacement. So it's not without its significant challenges, primarily because of the soft tissue, the patient, the age, and then the significant deformities. So these are the sort of the new generation implants, the second generation, which seem to be showing better longevity. So I'm just going to jump to another presentation. Give me a second there. Okay. So this is really what I'm getting onto, is that not all ankles are quite the same, you know, and when you trawl through the literature, no one really tends to look at these factors like obesity, age, deformity, surgeon's experience. It becomes quite tricky to get valuable data. As I said, just a bit of repetition about the etiology of ankle arthritis being mostly traumatic. But ankle arthrodesis was first described in the 1800s, and Sir John Charnley was the first to describe an X-fix compression of an arthrodesis, and then internal fixation with screws and plates has become, you know, much more common now, and arthroscopic techniques certainly in vogue and well practiced, first described in the 1980s. And ankle replacements first described in the 1970s with horrid results, and then a swing back to arthrodesis, and then through the 1990s and 2000s improving wear and improving longevity. So, and also understanding that if you look at these 20-year studies of ankle arthrodesis, it's not all that rosy, with significant subsequent surgical procedures on the foot or the ankle because of degenerate joint disease and this drive to try and maintain motion in the appropriate patients. So old generation implants being very well bonded to the tibia and constrained and using cement, and the newer generation implants being some of them with mobile bearings and some of them with mostly with fixed bearings, but with quite unconstrained designs, which is certainly mirrored what's happened in the other joints. If you look at the trends in ankle replacements, so certainly this is quite dated now, but if we look at the studies the data from 2010 to 2020, that graph is certainly increasing. But if you look at the graphs of ankle fusions and ankle replacements over the 2000s in the US, both are going up. So this tells us two things, obviously, you know, certainly population growth, and these patients are being treated as opposed to just given a disability grant or Brufen. But certainly ankle replacements are becoming much more commonplace. That's in the US, certainly. Yeah, when it comes to deciding on whether to do an ankle replacement or a fusion, my sort of criteria I look at are four things. One, age. I think it's pointless putting it in a 20 or 30-year-old. You know, you're going to be looking at a huge bone void and an amputation possibly after the second or third revision in time. It's a bit different in a very low demand, say JRA or rheumatoid type patient with multi-joint disease. Then you may consider it in a very young patient like that, but I try and stick to over 50 with reasonable soft tissues that are going to heal, patients who have a varus or valgus deformity that's not more than 15 to 20 degrees. That's, I think I can correct with the implant, otherwise an arthrodesis. And obviously with reasonable bone stock that's going to tolerate that implant, bearing in mind that significant load through the implant, distal tibia and talus. And they must have soft tissues that are going to heal. Otherwise, I'm going to do an arthrodesis arthroscopically. So yeah, those sort of 4 or 5 criteria. What about patient expectations? Well, interestingly, now these are more recent studies looking at quite carefully at patient-reported outcomes of ankle replacements versus ankle fusions, showing that expectations were much more likely to be met by an ankle replacement that worked. In these studies, they excluded patients who had revisions. So if they included the revisions, maybe the data would be a bit skewed. The patients that didn't have a revision, their ankle replacement expectations were met much more commonly, as opposed to an ankle arthrodesis. Quality of life following a total ankle replacement certainly mirrors the improvement that one gets after a hip or knee replacement if the survival reaches 5 years. And this is an interesting study looking at the total ankle replacement outcomes following an arthrodesis of the contralateral side. This is just a small study in 16 patients that didn't show a big difference in the satisfaction rates of both procedures. So yeah, that's quite an interesting one for the arthrodesis patients, but this was only a 2-year follow-up, and this might change. Obviously, one of the goals is to protect the other joints in the foot, and this might change at the 5 or 10-year follow-up if the ankle arthroplasty is still working. And then the costs are obviously quite a lot higher with an ankle replacement. What about a takedown ankle replacement? So it's a common question when patients say, "Cheapest, I need an ankle fusion. Can I change it to an ankle replacement in time?" And the answer is yes, you can. The results range from spectacular to terrible and quite hard to predict. Chris Coetzee in Minneapolis has done probably the biggest number, and he will admit that converting an ankle fusion to an ankle replacement is certainly technically not too difficult, but the expectations of the patients are difficult to meet in some instances with significant stiffness, muscles that haven't worked for years or decades even, and other joints that might have already degenerated, sort of clouding the picture. So, but yeah, to answer that patient's question, there is a possibility that you can take it down and convert it to an ankle replacement in the future. And there's currently a study ongoing in the UK. They continue to get more data, really looking at ankle fusions versus ankle replacements. It's a prospective comparative trial comparing these two outcome measures. So we'll get some more information from that study. Just want to show you 1 or 2 examples. This is a patient of mine that came to see me in 2016 with severe varus ankle arthritis like this. And the deformity seemed a bit too extreme to me to perform an ankle arthroplasty, although he was the right age and his soft tissues were good. Looked too unstable. So I performed an ankle arthrodesis on the right, open, got it quite well reduced, and it united, but then he developed subtalar arthritis within a year. So I learned 2 things from that. One, when there's a significant varus deformity like this, the subtalar joint is often unstable, and there's possibility of subtalar degeneration already, and you create the stiff segment and a pretty unhappy patient who required another operation, not within 18 months of the primary one. And this patient then came to see me a couple of years later, and he said he didn't want to have another arthrodesis, so I performed an ankle arthroplasty to go back to that severe deformity. when performing an arthroplasty in these cases, you have to try and balance the foot. The reason why his ankle developed a significant varus was a lot to do with his foot shape and his cava varus. So we had to perform an osteotomy of the first metatarsal over here, an osteotomy of the calcaneus to get him out of varus, and then a lateral ligament reconstruction. You can see the little drill hole there. And he's much, I can tell you now, he's much happier with the ankle replacement, and he's actually cycling multi-stage bike races now. So, you know, as you go along in your career, you start finding things that work better with in your own hands, of course, without getting too biased. It's another extreme case with valgus ankle arthritis corrected with ankle replacement. And so as you get more experience, as I've become more experienced, I've worked out that my limitations with the deformity are not as finite as they were some time ago. And I can correct a lot of these deformities through the joint. Okay, my battery's about to die. Mouth's dry. Need a beer. Any questions?